Tēnā koutou katoa, ko Fiona Graham taka whenua. I'm Fee Graham from the University of Otago, Wellington, here to talk to you today about telehealth and rehabilitation. So imagine for a moment that your boss walks into the office and tells you that from next month, half of all your clients are going to be seen by telehealth. What comes up in you? What emotions arise? What thoughts do you have? We asked this in a live presentation of this very same talk last week at the RTRU with a really wide audience, and that's some of the things that they come up with. What do you identify with there? What felt similar for you? What really jumps out as being quite different from your experience? And what have you heard before from colleagues? We've got a really wide range of responses. You can see there, a bit of something right across the spectrum, and from very strong positive and empowering emotions through to really negative perceptions of telehealth and experiences of telehealth. Some concerns about what that might mean for safety, for client safety, and their own professional skills and direction. And these are very much echoed in the international literature, exploring what telehealth means to different people. So today's presentation is going to unpack some of these experiences and emotions, and see if we can figure out together a way to go forward for you in the next steps. I am really curious about telehealth, and I think that it can work really well in some contexts and in some circumstances, but there are some significant caveats to the use of telehealth when it can work and not. So I'm not here to convince you one way or the other. I'm here to help you to unpack some of the nuance around telehealth to make more informed decisions about when it can be a better choice for someone that you're working with or a service that you're working in, and perhaps to understand some of the responses you're seeing from other health professionals about telehealth. But first of all, what is telehealth? Very briefly, it's the use of technology to deliver services at a distance that would otherwise have been delivered in person. So when we think about telehealth, often attention is drawn to that really high-tech and specialised use of resources, but it's important to think about the low-tech and very accessible options that most of us, especially post-pandemic, can access. We can think about telehealth as switching out something that was done in person with the use of technology to pretty much try and deliver the same thing, whether it's education, information, feedback, using technology instead and avoiding that travel time. We can also think about telehealth, though, in terms of doing things really differently. Providing resources so that people can monitor their own health, for example, with, use of sensors and apps that allow them to predict and monitor their own health and anticipate the need for health interventions before it becomes critical. So we can think about, both the infrastructure, kind of software such as apps, as well as hardware that enables people to live their fullest and best lives using technology. If we just dial it back a step, though, and think about what we need as healthcare providers in order to be effective. To deliver really effective rehabilitation, we need tools that work. Right? We need interventions that are established as being effective in achieving particular outcomes for particular populations. We also need to be able to provide those interventions at an adequate dose in order to reach a kind of intervention threshold in which the intervention can have the effects it's supposed to have. We also need to, doing one press up is not going to, give you amazing biceps. You need to be able to do so many of them in order to be able to achieve the gains that you're after. So we need interventions that work, we need adequate dose, and we need to reach the people who are most going to benefit from the intervention, and we need to reach a substantial number of those people, right? We want to reach all, or at least most of those people. As an evidence-based practitioner, you already know of the interventions that have the strongest research evidence that you're using in your practice. What we know in New Zealand and much of our public health sector is that we don't, and to be honest, private, is that we're unable to deliver the interventions at the dose that the research actually suggested that that intervention is effective at, right? Giving them a watered down version of the intervention. So we're going to get a watered down outcome for patients. And we know through the patterns of inequity and the difficulty with access that we don't, in fact, reach many of the people and populations that are most in need and most likely to benefit from the interventions that we offer. Now, you know what I'm going to say next, right? We know that telehealth can often help with that, improving dose and improving reach. And it might mean that we need a different type of tool. Different types of interventions work better in telehealth than they do in person, and they don't always translate between the two. And for many of us, this might mean learning different skills. We think about what life is like without adequate dose and adequate reach. It's a pretty boring PowerPoint slide, I can tell you, and it's not a particularly satisfactory way to work and achieve the outcomes with people that you've trained for, and which you know, and that are why you undertook this training. In terms of the research evidence, all I'm going to say is that a substantial body of research now suggests that telehealth is equal or superior to in-person rehabilitation. What you see here is just the first page of high quality systematic reviews around the use of telehealth. So obviously with systematic reviews and randomized controlled trials, we need to unpack that and look at how does this fit for this client that I have in front of me and their particular context. But if we're in a state of mind where we're thinking, well, telehealth is just not what I do. As an evidence-based clinician, we should be aware of what the evidence for telehealth is around the people that I work with to achieve the kind of outcomes that are important to those people. And that might mean learning to do things differently. It's certainly not a reason to dismiss telehealth, because the evidence is largely in support of telehealth. I did look, and I did very much look for evidence. I conducted the search in a way that evidence of negative effect or harm would have arisen in the search results, and I didn't find any. I didn't do an entire systematic review for this publication, although we did do a systematic scoping review here, the first paper referenced, and no evidence of harm was identified there. Telehealth provided access to services, particularly around complex wheelchair and seating, that several patients commented, I simply would not have attended the appointment if telehealth had not been an option. So providing that access in lieu of no access. So we've conducted a series of studies in New Zealand around the use of telehealth for complex wheelchair and seating assessment. Now you might think, why complex wheelchair and seating assessments? Jeepers, start with something a little bit easier. Well, it's somewhere that telehealth has the potential for significant gain, because it's a highly specialised area of practice that only a handful of clinicians are qualified to do and can do quickly and competently in New Zealand. So there is a tremendous wait list for wheelchair and seating assessments for when it gets into that complex range in New Zealand. And so we looked qualitatively and quantitatively at people's perspectives on what if a telehealth assessment service was made available? How would you feel about it? And as many others have found, patients were largely very positive about it. We were interested to note that the Māori wheelchair users were also very positive about it, and in fact suggested it might actually address some of the culturally unsafe practices that they had experienced, because they could easily invite support people to a telehealth meeting more easily than they could to an in-person meeting. For example, they can turn off the screen when they feel unsafe and several described situations where they're like, you know, I couldn't get the person out of my house because they wouldn't leave and I asked them to. That type of situation. Yes, in New Zealand. So I guess the message there is that how people feel about telehealth is not always what we're expecting. And so let's not make any assumptions. We're seeing in a study that we're undertaking at the moment, and it's echoed in the literature, is that the health professionals are the gatekeepers who decide whether they think telehealth is a good option for this patient. There's a fair whack of deciding whether I feel comfortable with telehealth. Do I feel safe? Do I feel like it today? And do I have any hesitations or concerns? And if they do, they don't offer it, rather than offering it, having a discussion with the patient about that and not making assumptions about what is going to be the preference of the patient. And in particular, Māori are generally offered telehealth less often. This is an emergent finding. We need to unpack that more. And that's out of a kind of cultural sensitivity, maybe oversensitivity, to the idea that, well, relationships really important to Māori, so I'd better offer it and make in person to ensure that that relationship's really positive. But if you're offering a Māori family the opportunity to be seen now or to be seen via telehealth or to be seen later via in person, many of them would prefer to choose in person. The key message there is don't make assumptions. I'm not saying that's a blanket experience, but it's certainly one that has come up in the research. There are other unintended consequences with telehealth. So when telehealth is an option in some other studies, people report seeking help more quickly when symptoms are more minor, because they're able to sort of self-monitor their health progress. Again, patients are more positive than clinicians repeatedly in studies about telehealth, both in giving it a go and in describing their experiences of it. Many health professionals are more positive about telehealth than they are when they've tried it than before that they've tried it. So if you haven't tried it, I would encourage you to give it a go and to think about what training and resources you need to support you with that. Many of us dived in there under COVID, but did we have training support? Did we know what the best practice interventions were around telehealth? Had we thought about the way that we do whakawhanangatanga, build relationship over telehealth, and how this might be different for an in-person approach? Many studies conclude that a hybrid approach is in fact better, a mixture of in-person and telehealth, and the ability to be able to choose and move between them. But as I said, most of the time it's the clinician making that choice rather than offering that to the patient. Other unexpected or unintended consequences are that health professionals have repeatedly reported a sense of threat to their identity and their personal roles when and boundaries when they undertake telehealth compared to in person, when they imagine undertaking telehealth. And yeah, this comes up repeatedly, and it's usually just touched on peripherally, and it very much warrants further exploration and support for health professionals. Because I suspect it's a significant barrier to health professionals even offering telehealth. So people often think about telehealth in this really pendulum kind of way. It's an all or nothing. I'm a telehealth person or I'm not a telehealth person, okay? And so what I'd like you to take away from today is thinking about where could I improve access and equity with a small bit of telehealth, thinking about that really wide definition of telehealth, rather than it being an all or nothing. All or nothing seldom do contribute to a better outcome for everyone. And some services in New Zealand have declared an all or nothing approach to telehealth, and if that's fine if you can choose between services, but it's clearly not going to work for everyone. So one study that we conducted in New Zealand during the pandemic was on the use of telehealth for children with neurodisabilities and their families. We took a realist lens to this. We looked at context, mechanisms and outcomes that were associated with positive telehealth experiences. Now, I don't expect you to be able to read the detail on this. I do have a selection of these publications, including this graphic, available if you'd like to come and see me after the presentation, and this is freely available online. So when there was a series of, if clinicians did a particular thing, then parents had this positive response to telehealth. And if they didn't do that particular thing, their families described, I would have had a negative response to this offer of telehealth. So it was things like offering a choice, right? Hybrid, we love choice. So offering it as a choice. So some clinicians routinely, with everybody, offer telehealth as a choice. Some families said yes, telehealth worked well. Some families said no, telehealth wasn't pursued. A focus on function. Therapists who used telehealth successfully, very much their goals were oriented around participation in life situation outcomes in the real world, rather than body structure and function based outcomes. And once they started engaging with the families at this level, it was much easier for families to be actively participated in. They felt heard and understood. She gets my real life kind of comments, and they felt that they could contribute, and indeed they could, because they know that family context. And the therapist used coaching type interaction styles, highly collaborative, repeatedly seeking the family's active involvement and their active decision making and contribution to treatment decisions. This indeed then led to improved access, more hands-on involvement from families. This is what we want when working with families. So more proactive management of their health, more accurate information to health practitioners as families were more actively involved, but they needed training and resources to do this and to move beyond the few who are currently doing it. So thinking again about what context is required where you are for better telehealth, use of telehealth. What does your context need in order to support your use of it? Mechanisms. What will you deliver in telehealth, in a telehealth session? And does that align with what you do or are able to do in an in-person? It's not necessarily the poor cousin. I think we need to get away from that mentality that telehealth is the poor cousin to in-person to achieve the outcomes that are important for your clients. So we're very much at the early adopter stage with telehealth. People are doing it if they are relatively high risk takers, and they're willing to persist beyond a health system and resources that don't necessarily support them to do it. And if we're going to move that over to the majority of health rehabilitation providers doing telehealth, then we're going to need to set up different systems and infrastructure. And with the revised health system, this is the time to do it. Think about the rehabilitation process for a moment. We know we go through this rehabilitation, right? Admission, we do assessment, goal setting, intervention, discharge. When could we involve telehealth in this? Could we send out some assessments for people to use beforehand via online questionnaires? Could we send them out goal setting information so that they can prepare ahead and start to think about what their goals are? Do we need to do that in a consult? What kinds of interventions that we draw from in our toolkit could apply to telehealth? Some will and some won't, but some will, and this can improve your accessibility to a greater number of clients than you currently offer. So thinking about our tools and what our options are throughout that rehabilitation process. Not only do we need training and resources, and we need people embedded in the culture to champion a telehealth model in order to realize the scalability potential of telehealth, okay? So we need to embed this in the system and potentially redesign the system. We might even need some of these sort of soundproof P-spots. An open plan office is not an appropriate context for delivering telehealth. Do we need an entire clinic space with a plinth in it? No, we don't need that either. So we might need to redesign some of our environments in order to deliver really high quality telehealth. So we are the gatekeepers to telehealth as clinicians, but should we be? And how much choice in that is what's best for everyone? I really challenge us boldly, and I appreciate that nervousness alongside everyone else about embarking into telehealth more wholeheartedly than we do. It is comfortable to do in person. We get more interpersonal feedback from an in-person, as in a positive emotions from in-person consults. It's tiring to look at a screen all day. Now, these are very solvable problems with some self-awareness on the part of the clinician that can potentially make telehealth available to more people that could benefit from it. So what choices could you make to improve access and equity in who receives the right amount of the interventions that you can offer, and how many people receive it? So I'm throwing that out to you as a choice for today. Kia ora koutou, ko Fiona Graham taka whenua. I'm here with you from the Rehabilitation Teaching and Research Unit. We're international leaders in postgraduate rehabilitation. Please, we would love to see you in the future. Ka kite anō.